This is Unit 4A, basically the respiratory lecture. I'm going to warn you now, it is long and a lot of information. However, it is extremely important in the pediatric patient, probably more so even than in adults. When adults go into cardiac arrest, most of the time it's due to cardiac issues. However, in pediatrics, a lot of times it is due to respiratory issues that then causes their heart to fail. So the respiratory system is extremely important in pediatrics and is very different in pediatrics than it is in adults. So at the core of all of this is the concept of gas exchange. If you can understand this, you can understand the respiratory system and a lot of other systems in the body. The gas exchange is the process by which oxygen is transported to cells, and then carbon dioxide is transported from the cells. Gas exchange and problems associated with impaired gas exchange, they involve a variety of physiological processes, and then categories that describe those processes are ventilation, transportation, perfusion. Pediatric differences in the airway. The respiratory tract changes and grows throughout 12 years of age. The airway is extremely smaller. It is shorter and narrower, and if you think about it, the neck is also very shorter and narrower than adults. The infant airway is only 4 millimeters in diameter, and the adult's airway is about 20 millimeters in diameter. A good way to measure it is based on the child's pinky, the end of their pinky. That is just a quick and dirty way to see how big their airway is. The trachea increases in length during the first 5 years of age. There is more flexible cartilage supporting the trachea, so basically it can compress with positioning, which is one of the reasons that they typically, when they intubate children, don't inflate the cuff. They usually leave it uninflated. And a narrow airway equals greater increase in airway resistance, obviously. Newborns, we've talked before, are obligate nose breathers. The alveoli increase in size and complexity after 8 years of age. The smooth muscle lining in the bronchi and the bronchioles react to irritants such as bronchospasm and muscle contraction. If you have a smaller airway, those muscle contractions are going to obviously be more harmful. If they are under the age of 6, they're going to use their diaphragm for breathing, and if they're 6 and up, they can use their accessory muscles better just because they have matured, the muscles have matured, and they have grown and developed those muscles. The children also have a higher metabolic rate, and so they need to consume more oxygen. This is talking about respiratory assessment. Here is a great YouTube video that goes over all of it. It is about 20 minutes long, but it does have some great pictures of what actual pediatric patients will look like when they're in distress. So some guidelines you should follow. Allow the child to be in a position of comfort if that means the mom is holding them or they're sitting up. You need to allow that to happen. Look out for those vital signs. You need to auscultate the lungs in all the areas. Look at the child. Look at how they're breathing. Are they using their accessory muscles to breathe, or are they breathing normally? Look at their color. Do they have good color? Are they pale? Or do they have some blue going on? Do they have a cough? You can ask the parents about behavioral change. So if they become less interested in running around and playing recently, and is there any family history of asthma or any other respiratory illnesses or recent respiratory illnesses. When the child is in respiratory distress, the body cannot maintain an effective gas exchange, which means there's insufficient oxygenation throughout the body. Hypoventilation of the alveoli results in hypoxemia, which is lower than normal blood oxygen levels. hypercapnia, which means you've got excess CO2 in the blood. So when both the oxygen and CO2 reach abnormal levels in the blood, you get hypoxia, which means they're lower than normal oxygen in the tissues, which is not good. And it's going to lead to respiratory acidosis. Here are your ranges. You guys should have already been taught about acids and bases and all the basic components. Respiratory failure, your initial clinical manifestations include restlessness, tachypnea, tachycardic, and diaphoresis. They're going to be sweating because they're working so hard to breathe so much harder and to get that blood flowing more. Early decompensation, if you see this, you need to intervene if you haven't already. They're going to have some nasal flaring going on, retractions, they may have some grunting, and they may have some wheezing. Again, they may have some anxiety and irritability. You can't, if it's an infant, you just can't get them to stop crying or calm down. If it's a toddler, they may just be irritable. If it's a teenager, hopefully they're going to be telling you what's going on. They may have some headache, confusion. Everybody may have hypertension and mood changes. If there's no intervention, like I said at the beginning, you're probably going to result in cardiorespiratory collapse, which basically means they're going to go into cardiac arrest, which could be fatal. Signs and symptoms of severe hypoxia, you're going to have dyspnea, bradycardia, cyanosis, stupor, and coma. And again, this is going to be before they're going to go into cardiac arrest. But if you see any of these signs, you probably should have already intervened and need to get the code card ready. So nursing care, you obviously want to recognize early on what's going on with them. You're going to do frequent monitoring. That includes a pulse ox. However, we all know that pulse oxes are late signs of respiratory decompensation. So your assessment is going to be vital. You know, how many times are they breathing per minute? How do they look? Are they retracting? You're going to want to elevate that head of the bed. You're going to want to have suction and oxygen available at the bedside, and suction if it's appropriate. Overall, you're going to want to decrease the child's anxiety and decrease their energy needs. You're going to administer as needed medication. And if anything changes in the child's respiratory condition, you want to notify the doctor as soon as possible. All right, so now we're going to go into the different respiratory diseases and illnesses that can cause some of the manifestations we've just talked about. Epiglottitis is inflammation of the epiglottis. It is potentially life-threatening. It's most common in ages 2 to 8 years of age. The HIV vaccine has greatly decreased the incidence of this. I have never actually seen it after working for 5 years in the pediatric ER. I did look it up, though. There's still about 200,000 cases in the U.S. per year. So it does still exist. However, the HIV vaccine has, like I said, greatly decreased it. The onset is typically abrupt, and the child rapidly progresses to severe respiratory distress. It is potentially fatal and is a very serious illness. The child may go to bed asymptomatic and then will wake up in the middle of the night or in the morning, and they're going to have a sore throat, pain with swallowing. They're going to have a fever. They are probably going to have a hoarse voice because their throat is becoming inflamed. May, like I said, even have difficulty swallowing. And as the airway swells, the child attempts to compensate for the occluding of the airway, and so they're going to do everything they can to continue to breathe, obviously. They're typically going to be in the tripod position, which is leaning forward. Their chin is thrust outward. Their tongue may be protruding. Their mouth may be open. It's clinically described usually with the 3 Ds, which are dysphagia, drooling, and distress. They're going to have some stridor. They're going to be restless. They're going to be very anxious with a frightened expression because they cannot breathe. You may do neck x-rays. It'll show you the epiglottitis is swollen and then the narrowing of the airway. Honestly, a visual inspection of the throat is a reliable sign. However, it is contraindicated unless you're ready to intubate, secondary to the possibility of the laryngospasm happening and the child just stopping breathing altogether. You're going to intubate the child, which is going to be challenging because their airway, their epiglottitis is going to be huge, and then their airway is also going to be inflamed. So you certainly want to have respiratory there and potentially a surgeon if you need to do a tracheostomy. The child's going to be on antibiotics for 7 to 10 days. Also going to be given steroids to decrease that swelling. It's going to be early, and then you're probably going to want to do it before you extubate them so that you can successfully extubate them. If they have a fever, you're going to want to treat that fever. If they aren't intubated, you're going to want to give them supplemental oxygen. That may help with the tripoding as well. It may help them feel like they can breathe better and get their oxygen levels up a little bit more, and so they will stop the tripoding. Nursing management, this is honestly throughout all of the respiratory lecture, and so I'm not going to repeat it for every disease. But you want to allow the child to remain in the most comfortable position. So like I said, if that means their mom is holding them, that means they're sitting on the side of the bed, you want them to be comfortable. You want to decrease their anxiety, and you want to make sure that you have the appropriate equipment at the bedside. You're going to want to continuously monitor that respiratory status like I had talked about before. Look for retractions, all of that. All right, so now we're moving on to croup, which if you've heard anybody who's had croup, you will never forget it. It sounds like a barking seal. And it's inflammation of the mucosal lining of the larynx and trachea, which causes narrowing of the airway. It's typically caused by a virus, the parainfluenza virus, the influenza virus, RSV, or the adenovirus. It's getting to be about that time now that everybody's going to be adenovirus positive or influenza positive, and so everybody's going to have to be isolated. It typically happens in about 3 months of age to 8 years of age. The onset is gradual. It usually begins at night. They wake up with that barking cough. It typically manifests itself as a URI, and then the airway becomes narrowed and the child struggles to breathe past that narrowing. It can progress to symptoms of respiratory distress. It doesn't always. You may just, honestly, the child may just wake up in the middle of the night with that breathing and that barky cough. A lot of times the parents will take them out into the cold night like now, and that helps to decrease the inflammation, and so the cough goes away, and then they get them to the ER and they're okay. So it does not always progress to symptoms of respiratory distress. Like I said, they may just have that annoying barky cough. They're going to have a low-grade fever, inspiratory stridor, that barking cough that I've talked about, URI symptoms. For diagnosis, you're going to want to get a history and a physical exam. Honestly, you're probably not going to do a chest x-ray or an x-ray of the neck unless you believe that they may have some pneumonia or you hear something iffy on your respiratory assessment. If they're getting admitted, you're probably going to draw a CBC, so you're going to want to look at their white blood cells, and you do not want to do throat cultures or a visual inspection, both contraindicated and may cause a laryngospasm, just like it was contraindicated with epiglottitis unless you're intubating. If they are admitted into the hospital, you're going to want to give the medications as scheduled. You're going to want maybe to humidify the air to them. You're going to do supplemental oxygen as needed. And again, have that intubation equipment ready. If they go home, sometimes in the hospital we do this thing called a cool mist, where basically we just put some ice cubes in a saline with the neb set up and blow it on their face, and that just helps to calm them down and then also to decrease that swelling. I don't know that you would necessarily send that home with the parents, but sometimes we do it to decrease the amount of stress in the hospital. You are going to give nebulized epi in severe cases of this. You're going to want to be sure that the child is hydrated with cool, non-carbonated, non-acidic drinks, IV hydration if it's necessary. Your main line of defense with them is typically corticosteroids to reduce that inflammation. You're going to give them dexamethasone, usually IV or by mouth. A lot of times, like I said, when they get those children out into the middle of the night and then they come in and they no longer have that cough, we may just give them a dose of PO dexamethasone or Decadron and watch them for an hour or two, see if they rebound. If they don't, they typically will go home. And that Decadron kind of it's only a one-time dose. It takes care of it then. You're going to give an antipyretic if they do have a fever. Most of the time it's only low grade. You're going to continuously assess the respiratory status like we've talked about, conserve the patient's energy, encourage fluids, provide comfort, support the parents. All right, so another disease is bronchiolitis, which is inflammation of the bronchioles, which is the area between the bronchi and the alveoli. This is going to be either an acute viral or bacterial infection. RSV is the most common cause of bronchiolitis, and it usually lasts 7 to 10 days. Most common ages is 2 to 6 months, especially with RSV. It's most common in the infants or children with heart and lung disease. It typically begins as a mild URI, so they're going to have nasal drainage, sneezing, cough. They're probably going to have a fever. You're going to want to treat that fever. If they're less than 6 months, you can only give Tylenol. And then they're going to gradually increase in that respiratory distress. They're going to become tachypnic. Their cough is going to become more frequent. They are going to wheeze, even though they're not asthmatic. So just because they're wheezing with bronchiolitis doesn't mean they're asthmatics. It just means that it's a manifestation of the disease. Parents don't typically understand that, so it's important to explain it to them. They are going to have retractions. They're probably going to have crackles. They will have poor feeding. They're going to have nasal flaring along with a bunch of nasal secretions that are all up in there, and so that's why they're having poor feeding, because they are obligate nose breathers. Just to bring it all together. Cyanosis is a late sign. The inflammation of the bronchioles leads to the airway edema, which produces excessive mucus. And so the lumen of the bronchi fills with exudate and mucus, which leads to that wheezing and dyspnea, bronchospasms, and you may have some atelectasis in there and hear it. Their respirations are going to be rapid and shallow. Again, nasal flaring and retractions. You may even have some diminished breath sounds. Like we talked about, they're going to have difficulty feeding. Diagnosis, you're going to want to look at the clinical presentation and the age of the child, and you're going to do a nasal culture, which is the only way to diagnose it, and send it off, and they will call you back that the child is RSV positive. You're going to do high humidity with or without oxygen, typically by a face mask. You're going to make sure they have adequate fluid intake, IV for hydration, promote rest. Okay, so this is a little controversial in the hospital. Bronchodilators are no longer recommended for bronchiolitis. The exception is hypertonic saline for hospitalized infant. So typically if they come in with bronchiolitis into the ER, what you're going to do is suction all that gunk from their nose. You're going to do some deep suctioning and really try and get it out so that A, they can breathe easier, and B, hopefully that they will feed. You're probably going to give a hypertonic saline to them as well. Now, some doctors hear the wheezing and they think that, oh, well, we're going to go ahead and give them albuterol. However, it has not been proven to actually help the child. You're just going to get the side effects of albuterol with the high heart rate, and not really any results. Ribavirin is an aerosol antiviral that's given to a severely ill infant. So this is usually given in the NICU, and it's given once the child is sick, and it's 12 to 18 hours continuous. It is a long treatment course. That is to treat RSV. Synagis is immunoglobulin for RSV. Again, this is typically given in the NICU. It's given to prevent RSV to these high-risk infants and children. It's given monthly from starting in October or November through April, and it's 15 mg per kg given IM. These RSV babies, you want to isolate them from others because RSV is transmitted by close contact. You want to practice good hand washing. You want to maintain those patent nares and airways. So again, you're going to do deep suctioning, and you may have to do it frequently to be sure that they can feed and to decrease all of those secretions and hopefully make them less tachypnic and retract less. You're going to elevate the head of the bed. These are the same we've talked about for all the other respiratory issues. Have that emergency equipment at the bed. Okay, another one is the foreign body aspiration. This is an inhalation of any object into the respiratory tract, either solid or liquid, either food or non-food. Small children are prone to aspiration, not only because they explore objects with their mouth, but they're curious and they pick up little things on the floor and on the table and everywhere and put them in their mouth, and so they're just prone to it. It's most common between 6 months and 4 years of age. A lot of times, if they have inhaled something, it's going to go into that right bronchus or that right main stem. It's a shorter length and it's a straighter angle. This is just an aside that you don't need to know, but it's interesting for when you are working. If somebody does not intubate properly, they are typically going to go into that right main stem, or if they over-intubate, they're going to go in the right main stem, again, because it's a straighter angle and it's right there. So clinical manifestations really depend on the degree of the obstruction of the airway. Do they have a complete degree or do they have a partial degree? Also, depends on the nature of the foreign object. Is it food or is it non-food? You may do a chest x-ray for a diagnosis, or they may do a bronchoscopy where they actually go down into the lungs with a camera and see what's going on. These are the most common objects aspirated. On one of my previous lectures, I mentioned to you guys about the child that aspirated the popcorn. I've certainly seen many children aspirate other things, so you want to look into it. I do want to clarify, just because they swallow something does not mean that they've aspirated it, like coins. We would have children that would have swallowed coins and would come to the ER, and we actually had a metal detector because we needed to decide where to do the x-ray to see the coin, and if it if the metal detector didn't go off until it got to their belly, we did an abdominal x-ray, and if it gets past their lungs and past that area, usually they're fine and they'll just pass it through their stool. So again, just because a child has swallowed something does not mean that they've aspirated it. If they have aspirated it, however, initially they will be choking, they may gag, they may have some restlessness, their lips may turn blue, a partial obstruction. Symptoms develop within hours, actually, days or weeks after the initial symptoms. They may not develop immediately, obviously, like a full obstruction would. Most common symptoms, you're going to have stridor or hoarseness because their throat is partially obstructed. You're going to have coughing, and again, you may have some cyanosis with dyspnea or with wheezing because they're not getting all that air in and out properly. Medical management, you may do surgery to remove it as soon as possible if it is occluding that airway. You may do a cool mist in the hospital, antibiotics if it's appropriate. Again, keep the child calm and quiet. Obviously, if there's a complete obstruction, you're going to do the Heimlich maneuver immediately, and you want to alter the child's environment to provide calming measures. So this is leading into allergies, which can lead to respiratory issues in children. And I'm just going to review briefly the antigen-antibody response, which we actually kind of reviewed with immunizations. But an antibody directly attacks or destroys antigens in your cells. It's either before or after the antigen invades the body cells. A lot of times an allergen is seen as an antigen, and so the body recognizes it as being foreign, and then it attempts to neutralize or destroy it through an immune response, even though it may not be something bad. So you're going to have a hypersensitivity response, which is an overreaction of the immune system, which leads to an allergic reaction. You're going to have a primary immune response once you have an initial exposure to the antigen or the allergen in this case, and it's going to react specifically to that antigen from then on because you're going to produce those antibodies against it. Again, subsequent exposures, you can have a hypersensitivity response, and then you're going to have an allergic reaction. IgE attaches to the surface of the mast cells or the basophils, which reacts with the specific antigen. And then the mast cell ruptures, releasing chemical mediators, which causes histamines and serotonin. Clinical manifestations, you're either going to have a localized response or you're going to have systemic, which is anaphylaxis. Localized response, you're going to have rashes, eczema, contact dermatitis, or a GI spasm like diarrhea. Systemic, think about anaphylaxis here. You're going to have hives, respiratory distress or wheezing, hypotension. You're going to have a bronchospasm, and it could actually eventually lead to shock. To medically manage this, you're going to give antihistamines to counteract the histamines that your body is releasing. So like Benadryl or Atarax. You're going to give inhalants like cromolyn sodium. You're going to give corticosteroids, either topical or systemic. You may even do immunotherapy or desensitization like the allergy shots. And you're going to make sure the family knows how to use an EpiPen for a severe reaction. And school nurses, just as a side note. For allergic rhinitis, you're going to have which is basically your nose is inflamed. It can occur seasonally, which is the most common. It may be recurrent if you have specific triggers in your house, like mold or mildew or something like that, or you're allergic to cats and you have cats, so you may need to be on something long term for that. Just talked about that. depending on the time of year, it can also be with the trees or weeds or grasses. We talked about that. Clinical manifestations, you're going to have sneezing, an itchy nose, eyes, ears, mouth. You're going to have nasal stuffiness. You're going to have clear nasal drainage. You may become a mouth breather, which results in dry lips. It's not fun. Allergies are just not fun. You might have allergy shiners in your eyes because they're swollen. The allergic salute, which is when you push your nose up and you've got that line on your nose. You may have pale bluish gray turbinates. You're going to have pale boggy nasal mucous membranes that the doctors can see. So they may put you on some decongestants like pseudoephedrine, which is Sudafed or Afrin. They may put you on a nasal steroid such as Flonase. Allergies go hand in hand with asthma, and I swear Richmond is like the asthma capital of the world for children. Asthma is an obstructive lung disease of the airways. You guys know this. It's characterized by reversible hyperactivity of the bronchi and the trachea to a variety of stimuli, which typically tends to be allergens. It's one of the most common chronic disorders in children. And it's basically chronic inflammation, and you're going to chronically produce bronchial mucus. The airway is going to become narrowed or obstructed. It's inflammation, it's hypersensitivity and hyperresponse. We've talked about the triggers. It's going to be the same, except you're going to have exercise can trigger it, as well as illnesses. Cold air can trigger it. Medications can trigger it. Changes in the weather or temperature. Animals, foods, stress or strong emotions can trigger it, especially like panic or anxiety. With asthma, you're going to have rapid labored respirations. You're going to have tachypnea. You're going to be using those accessory muscles. You're going to have an expiratory wheeze, and you're going to have a dry cough. It tends to be different than all the other coughs we've kind of talked. The rest of them tend to have some mucus in them. Asthma, you just tend to have this dry cough. If you have a mucousy cough later on in asthma, it is going to be, if you have a mucousy cough, it's going to be later on during the illness with asthma. At the beginning, it typically tends to be that dry cough. Again, same clinical manifestations as the rest of any of the respiratory issues. Something different is you may have a feeling of tightness in the chest because your airway is literally getting tighter and is getting smaller. Really, you want to educate the parents on avoiding the triggers if at all possible. You want to do regular peak flow monitoring to know. You want to know what they are at their healthy range. And so then if they are starting to decrease in their peak flow, you know that they may be starting to get sick, and you can kind of catch it before it gets too bad. There are a ton of medical managements out there, or medications. There are oral medications, there are inhaled medications, there are systemic medications for asthma. Pharmacological treatment is based on the severity of asthma for long-term control, and then you're also going to have some rescue drugs for the management of acute episodes. Hopefully, if you are on long-term control medicines, you don't have that many acute episodes, but that's not always the case, especially until you get the right control medicines. So you're going to have a bronchodilator. This is the drug of choice for an acute asthma attack or exercise-induced asthma. You've got your short-acting ones like albuterol and levoalbuterol. And then you've got your anti-leukotrienes like monoclast. You've got your anticholinergic, ipratropium or Atrovent. You've got your long-acting beta-2 agonists like Solumedrol or Motorol. mast cell stabilizers, so they are actually inhaled non-steroidal anti-inflammatory. So these are long-term. Again, I've mentioned this before, but cromolyn sodium. You've got your corticosteroids, nebulized versus systemic, prednisone or Solumedrol, you're probably going to be on short term. Whereas like fluconazole or beclomethasone, you may be on long term to help the chronic inflammation. Like I said, albuterol is the first line drug. It is a smooth muscle relaxant, and it helps to stabilize those mast cells to prevent the release of mediators, and it helps to decrease that swelling. It's going to be nebulized, and you're going to have an inhaler with a spacer. That spacer helps children and adults by inhaling. I actually have read research where if you don't have the spacer, the albuterol it's really not nearly as effective as it is with a spacer. Everybody hates the spacer, but it really does make it more effective. And the medicine kind of sits in there so that you can, all the breaths that you're taking, you're breathing in all of that medicine so that you can get all of it. Monoclast is a long-term control agent like I talked about before, and it decreases the inflammatory process of asthma. Atrovent provides bronchodilation without systemic anticholinergic properties. It dries up the secretions. It prevents bronchoconstriction. It is a delayed onset, and it's not for primary treatment, but can provide additional effects basically to albuterol. So what we do typically in the hospital is when they come in the ER, we give them 3 back-to-back albuterol Atrovent treatments, and then after 3 treatments of Atrovent, you've reached the ceiling effect, and so you don't give any more Atrovent, but it is used in acute exacerbations, not for long-term management. Solumedrol and formoterol are bronchodilators as well. It's a central nervous system stimulant, increases respiratory muscle contractility. This is not used in acute, it's used for long-term, hence long-acting beta-2 agonist, but it's used for long-term control. Cromolyn sodium is Intol, which is an anti-inflammatory, and it acts superficially to inhibit the mast cell degranulation. It does not reverse bronchospasm, and it does not work in acute attacks. Actually, all of your long-term steroid medicine, or all of your long-term medicines that are targeted toward asthma are not going to work in acute attacks, so don't even bother using them. Like I said, go straight to albuterol, and then in the hospital we'll use Atrovent. Most of the time they don't have Atrovent at home. Corticosteroids, prednisone and prednisolone are both oral. They obviously help to relax those smooth muscles and decrease the inflammation. Solumedrol is given IV. You're going to have some nasal corticosteroids as well. They decrease, I just talked about this. You either give it daily or every other day in the AM. You want to taper the dose. You don't want to stop it abruptly. You want to give it with food because it can cause GI distress. And then you don't want to give these long term. You might have decreased growth, unstable blood glucose, and immunosuppression. Nursing management, we've talked about this before. Educate the child and the parents on the disease. You want to try and eliminate those triggers if you can. Certainly you want to educate them on medications. Something important for asthma is that they have medications for both home and school if they're going to use them at school. growing up, I had childhood asthma, and we had to have an inhaler for at home, and an inhaler that I had to take 20 minutes before gym class because I had exercise-induced asthma. And so you want to be sure that they have all the medicines that they need along with the instructions. You want to teach them about the signs and symptoms of asthma, especially the early signs and symptoms. And then we already talked about a peak flow meter, how you can really catch it before it gets too bad based on their peak flow measurements. Same nursing management as everything else. Status asthmaticus is unrelenting severe respiratory distress and bronchospasm, which are the kids that no matter what long-term therapy they've been on, it's just not working. And it may progress to respiratory failure and death, and it may require intubation with ventilation, which obviously you don't want to intubate an asthmatic because their airway is already swollen, and so it's going to be difficult. Thank goodness now, mostly with all of the long-term medicines that we have for status asthmaticus, or for asthma, it doesn't get to this point, but there still are children that do actually die from asthma. All right, so this is the last respiratory disease that we will go over, so we've made it, which is cystic fibrosis. It is a multi-symptom disorder. It's not just a respiratory disorder. It affects the exocrine glands, which are mucus producing. So it increases the viscosity of mucus gland secretion, and it produces abnormal levels of sodium and chloride. Like I said, it's more than just respiratory. It's GI, it's your skin and your reproductive systems as well. It is an autosomal recessive inheritance pattern, so each parent carries the gene for the child to be affected. And since it is recessive, it doesn't mean that the child will be affected. It just means that they can be. I know a family where the parents have 2 children and the girl has it and the boy does not. So there is an increase in sodium and chloride in the sweat, and 2 to 5 times greater in the sweat for both. There is an increase in the incidence of diabetes with them. Unfortunately, most of them will develop diabetes at some point in their life. Their mucus glands produce thick and sticky mucus, which accumulates in the organs, typically in the pancreas and the bronchioles. And the pancreas is also not going to produce the enzymes like it normally does, and all of that sticky mucus can cause obstruction. So the respiratory system, there's an increased viscosity of the bronchial mucus, so it's very thick, and it slows the flow rate of the mucus, and so they can't expirate it. It's incomplete expectoration, so they can't cough it up, they can't clear it on their own, and so that retained mucus is an excellent medium for bacterial growth and lung infections. Hence, all of the PT that we do and trying to get rid of all of that mucus, and typically if they are admitted, they have a lung infection due to that mucus just sitting there and doing the bacterial growth. It's also why a regimen for them is so important, and sticking to that regimen is important, which can be difficult in children. There is a decrease in the oxygen and carbon dioxide exchange, which can lead to hypoxia, hypercapnia, and acidosis. They're gonna have chronic problems. This is a chronic condition that will be with them for the rest of their life, unfortunately. They can have bronchiostasis, they may develop a pneumothorax, they may have pulmonary hypertension, they may have cor pulmonale, they may end up in respiratory failure. Again, with the treatments, the goal is to prevent them from ever having an infection and ever developing any of these things, but it is a real possibility for them. In the GI system, that thick mucus is the same, and it blocks the ducts of the pancreas. And so, like I said, the pancreas isn't going to produce those digestive enzymes, and they don't reach the duodenum where they need to be. And so the intestinal mucosa is unable to absorb food and nutrients. They have an impaired ability as well to absorb fats and fat-soluble vitamins such as A, B, E, and K. And that non-digested food is excreted, and so their stools tend to be large and foul-smelling. And it is very difficult for them to gain weight. And so a lot of times they're going to decrease their weight because they just cannot absorb what they're eating properly. And that's a big thing that they do at the clinic outpatient, is watch their weight. And sometimes, if you know an exacerbation is coming, is based on they're losing weight instead of gaining weight. Their GI system, they're going to have muscle wasting and sometimes abdominal distension. They may have a prolapse rectum, which basically means that the rectum is prolapsed, so it's outside of their body. It's crazy if you've ever seen one. And it is the most common GI complication from untreated CF. So sometimes if they're a baby and they haven't been diagnosed with CF and they have a prolapse rectum, they're probably going to test them for CF. They may also have a meconium ileus, which is a first sign of the disorder for some children, about 10 to 15%. The reproductive system, they may have a 2-year delay in the development of secondary sexual characteristics. Females, their fertility can sometimes be inhibited by viscous cervical secretions. Males are usually sterile because their vas deferens are blocked with those abnormal secretions, and they may not even ever produce any sperm. So their skin is also affected. The chloride channel is defected in the sweat glands, which prevents reabsorption in sodium and chloride, which is why they're going to have the increased sodium and chloride concentration in their sweat. And that's typically how they are diagnosed, is by their sweat test. They are obviously then at risk for dehydration and salt loss as well. Like I said, here's how they're diagnosed. They do a sweat chloride test, and there are the levels. They may have a positive family history as well. They're also going to do pulmonary function test, which they do pulmonary function tests a lot throughout their lives in the outpatient world, and that is how they kind of monitor the progression of their disease, and if they need to be admitted because they're having an infection or something like that. They really use those as thresholds for them. Diagnosis, they may also do a chest x-ray. They may do a stool test, which would be positive for fats. Definitive diagnosis is 2 positive sweat chloride tests, and then the classic symptoms like we've talked about. Medical management, you're going to have beta-2 adrenergic receptor agonists, like a bronchodilator. They're probably going to have hypertonic saline at home. They're going to have alpha dornase, which is homozyme or binase, which is an inhalant. So it's going to go into I don't believe this one, I think you have to use a face mask for this one. It doesn't go into, it doesn't come in an inhaler form. It comes in a face mask form that you have to do. And again, it's 2.5 milligrams either every day or 2 times a day based on the pulmonary function test. This decreases the viscosity of the mucus, and this is typically done before you do the therapy, so either before they wear the vest or before they have somebody come in and beat on their chest and back to break up all of those secretions, because this is going to decrease the viscosity of that mucus so that they can cough all of that up. Antibiotics, if they do get a lung infection, they're going to require higher doses because they metabolize it more rapidly. Piperacillin is one of them that is given IV. Topramycin is probably given more frequently IV. You also can give a localized neb treatment. You can give topramycin via nebs as well. That is a longer course, but you can do that at home. You're going to want to give them oxygen if they're having an acute episode. Like I said, you're going to have chest PT done at least twice a day, if not more, and they typically will either have a vest that they do at home, or they have either a parent or sibling or something that will actually physically do it. They also are going to have a bronchodilator like albuterol. Exercise is, we want them to be as normal as possible, but it can be hard because they are losing so much in that sweat, and then it also may affect their breathing. So just think about that. Swimming tends to be better for them because it's just less hard on their body. Pancreatic enzymes, you are going to give that to replace the enzymes that their body is not making. And these are given anytime the child eats, including meals or snack times. They are capsules, so they're swallowed whole once the child can swallow pills. And if they can't, you can open up that capsule and sprinkle it on the food. You want to make sure that they have a high-calorie, high-protein diet because they are losing so much and it's so difficult for them to lose weight. You are going to want to give them fat-soluble vitamins, and you're not going to have any fat restrictions. You may give salt supplements in hot weather or physical exertion like we talked about, or if they're having a fever. This high-calorie, high-fat diet, or high-calorie, high-protein diet can become very hard when you think about it, if they develop diabetes. So this disease does become very complicated. The median lifespan, it used to be their late 30s. They are living longer and longer, but they certainly don't have the full life trajectory that people without it have. There is no cure as of yet. The gene has been isolated. Today, at some point when their respiratory system becomes compromised, they typically are worked up for a dumbbell lung transplant. Nursing management, you really want to support the child and the family. They are dealing with this every day, all day. And you also want to educate the child and the family on the disease, on chronic illness survival, and on the medication, the chest PT, and the diet. Like I said, they are dealing with this all day, every day. While there is not a cure for it yet, there is a pill that actually they are doing studies on at VCU. And I mentioned my friend who had 2 children, and one of them, her daughter, has it. She is currently on the pill, and in the CF world, they are quote-unquote calling it the cure pill, because what it does is it basically stops the disease where it is, and it stops it from further progressing, and so it stops it from further harming your lungs. Since she has been taking that medication, her pulmonary function tests have never declined, and she has not gotten a bacterial infection. So they are hopeful that this medicine is going to be effective and help the child. Like I said, she's been on it for probably a year or so, and so it is certainly working so far, but we will see how long it lasts, hopefully for a very long time. They are working very hard to find a cure for it. So that is all. I apologize for the long lecture, but like I said at the beginning, respiratory is very important in children. Please let me know if you have any questions.